Okay, so we're about to start here now. I know some people will be coming in. I want to thank Gigi and the NAMI team for inviting Nicole and myself here to speak. And Nicole, you will be a tag team here. And if you see someone raising their hands, please, we'll take questions as long as we have time throughout the presentation. If you have a question, just raise your hand and one of us will call on you. So our top, yeah.
I got it.
Okay,
Yeah.
so our topic today is what do you need, what are you entitled to, and how do you get it? And this is regard to mental health services. And why do we have to even discuss this, folks? Let's face it, if you had a broken leg or pneumonia, is there a question? You go to the emergency room and they treat your broken leg, right? It's kind of straightforward. Why does it have to be different for mental illness? It's against the law for the emergency room to refuse treatment. It's against the law for them to give inadequate treatment, and it's against the law for them to discharge you before you're stable for discharge. It should be the same for mental illness. It's not. When we all know that mental illness is a brain illness, aren't these illnesses entitled to the same treatment? We would think, yes, everyone in this room would. Now, in the United States and in California, we have what's called the Mental Health Parity laws, which Nicole is going to help explain. Very, very important.
Right. Thanks, Debbie. Quick introduction. I'm Dr. Nicole Stelter. I'm the Director of Behavioral Health Clinical Strategy and Programs at Blue Shield of California. It's a nonprofit health insurance plan. I think you
Can everyone hear her?
Can you? Oh. How about now? Okay. Sorry, I should have done not the slide. I was talking in the wrong end. Okay. And so part of what my team does is the systemic and policy changes, including our own policies and products. And oftentimes what we come up against or what we're trying to find a way to translate is parity law. There's both federal and state. Some of this may be redundant. A lot of you probably already versed in this, so apologies for that, but I'm going to try to start with just very much an overview. So federal parity has been in place for some time. And originally that was for group health, meaning employer-sponsored care, but only for a certain size or on a certain kind of insurance plan. That was recently removed, which is great. That's been an update recently. And then also broadening the scope to include substance abuse because it wasn't initially called out. Substance abuse and addiction wasn't included in the conversation as much as it should have been. So those are very good advancements on the federal side. There are some exclusions, older companies that were in place before 2008. They're oftentimes grandfathered in or they can ask to be excluded. That's a whole nother conversation. So it's not 100% of health insurance plans, although it should be, but that's something to keep in mind. The basics of it, two quick basics to keep in mind, and I'll talk about California. The benefits for addiction, substance abuse, or substance use, and then mental health care and psychiatric, or both, because sometimes it needs to be both. Those benefits have to be quote unquote equal to the medical side. And when I say quote unquote, there is a lot, equal sounds like it should be pretty straightforward, and it's not, and hasn't been, and has been a major source of contention in our space. The other thing that has to be quote unquote equal are the processes. And so what that means then is for knee surgery, if Blue Shield asks you to do one pre-authorization or one, visit with a specialist before you have surgery, I can't make you visit with 10 before you have inpatient psychiatric care. That's a really oversimplified example, but it's important to know that it's not just benefits, it's also the processes. Because of California passing not only their own parity law, but then our own, parity law, but also most recently Senate Bill 855, there have been a number of improvements in how we look at the process of getting outpatient care. And when an in-network provider isn't available, that's no longer on on us as caregivers or as patients to find an in-network provider or pay for it out of pocket. That has to be covered now by the health plan. That's a really important point to keep track of. Correct. That's right. Which is great. So, yes. Yeah, as of July 1st. Is everybody, yeah, let me make sure. Yeah, I will. Sorry, thank you. She was clarifying whether that then insurance companies have to pay for an hour of network provider or facility, so not just outpatient. The answer is yes. And it's up to us, so me as Blue Shield, to find that. It's not on you. And sorry, what was the other one? I'm sorry. There was another one you said. Oh, it's in force now. It came up.
Out of network.
Out of network.
So if they have a panel of 20 names and none of those are available, then they have to find someone outside that panel.
Right. And so the example for a facility would be, and this comes up in residential treatment quite a bit, right? Where there's a very specific niche. I work a lot with first responders in my clinical practice. There's a really specific niche of addiction care that they can't just go to any facility to get good care. And so oftentimes those facilities aren't though in network, and we end up having to negotiate that. And
well, I'm in that situation right now with my daughter.
So let's not talk about particular situations now. Okay, we're going to talk about the general information, and then we can talk about more specifics later. Is that okay? Are you finished, Nicole?
Let me just say a couple more things that are important, and I can stick around afterwards too and make sure, because some of this is not entirely straightforward. So the process and the coverage are the two important things to remember. The process now that's been improved is the SB 855 with the state of California. The other part of the process is, and I think this is what you're going to get into, Debbie, is the use of the criterion, quote unquote, medical necessity.
I'll be getting into that.
Yeah. One thing I want to point out about that is that's another thing that has a lot of grayness to it. The state of California is working very hard to decrease the grayness of that, which is fantastic. That's also part of 855. But there's still a lot of opaqueness to that conversation. And the thing I want to make sure that everybody knows here is that when a insurance plan says to you, it doesn't meet medical necessity, or it doesn't meet medical necessity for inpatient, but you can have outpatient, whatever that medical necessity claim is, you have the right to request, and they're required by law. We're required by law to send you that criteria in a way that you can then understand it, not just my policy that you can't read because it's full of legal talk. So please keep that in mind.
Okay, thank you, Nicole. So how do you determine what you need or what your loved one needs? You know, as the example, if you break your leg, it's pretty straightforward what you need. So the first place to go is your mental health provider, your doctor, the team. Hopefully they would recommend what treatments and medicines are needed. But unfortunately, sometimes they'll restrict their recommendations to medicines that's on a limited formulary, to inferior treatments or maybe low cost options. Is that enough? Not necessarily. So another place to go would be NAMI support groups. How many people here, I know that table, are in NAMI support groups? Because, thank you. In the NAMI support group, it's a great place to start. The collective knowledge of everyone in the group. I mean, you can ask questions. I keep learning so much from the wonderful people in my support group. I continue to learn from them. No one person knows everything. So if you bring up an issue, often someone in the support group has had that issue, or many people have had that issue, and they can share, what helps. Check the NAMI GLAC calendar. There are support groups for families and for individuals almost every day of the week. And that's a great place if you're a peer. A peer support group is great. If you're a family or loved one, the family support groups are great. The internet is also a really good place to look, maybe, sometimes, but be careful. Do you believe everything you read? Yeah, I mean, some of you are too young. Many of you, I remember in the old days on TV when a doctor, a man with, always a man, of course, with a white coat would recommend a brand of cigarettes. I do remember that. Anyone here remember that? Yeah. So, be careful what you read, and nowadays they advertise. I know I see frequent ads for detox and sober living houses. They're usually in Malibu overlooking the ocean, and they quote 95% cure rates. So you have to be careful when you look on the internet. What you want to look for some studies. Went ahead. You want to look at evidence-based studies. In other words, if a drug company is touting their drug, they're not necessarily unbiased. Okay, but evidence-based studies use valid scientific method to study and research the topic. They're peer-reviewed articles, which means experts in the field look at the articles. Yes.
A lot of studies have bad.
Okay, what is evidence-based? Well, if it's in a peer-reviewed journal, then that's going to be pretty much evidence-based, but that's a good question. Go ahead. Huh? Okay, not always, but that's a good place to start. That certainly there are exceptions. I know it's hard for me to read law school journals. I can't. It's a foreign language. And it's really hard for most people to look at a medical article, look at the methods, the conclusions, and everything in between, and determine if it's an evidence-based study. But that's a hard thing. Hopefully experts in the field. Yes?
200 publications. And I agree with you about evidence-based, but the average person isn't going to be able to read the article, understand the article, and know whether it's evidence-based. So what do you suggest for the person who can't read the statistical evaluation, doesn't know that, doesn't know how to?
That's a good point. I want to finish on, and I'll just mention briefly that, if you have experts, some experts are in the field, that if you have a respected expert, they can give you some guidance on that. But that's a good point. You're ChatGPT, who I'd be careful again that, some of that stuff is certainly not evidence-based. So I want to just move on here to what are you entitled to? So Nicole did a great job of explaining that mental health parity law, that we're entitled to appropriate services that are similar in scope to services for a medical surgical kind of problem. And the major criteria for the insurance company is medical necessity. And that certainly can be a gray area, but I have here 6 criteria that I look at. And that is it needed? Is it appropriate? Is it reasonable? Is it evidence-based? Is it community standard? And is it not for convenience? So those are our 6 criteria that are very good at defining, as best as one can, medical necessity. And you are entitled to what is medically necessary for treatment of any mental health issue, problem. And a place to look at would be the website for the Department of Managed Healthcare. And I'm going to actually walk through that website with you. So it's a gold mine of information. So the Department of Managed Healthcare is a consumer protection agency in California that oversees the operation of most managed healthcare plans, employer-funded, individual, Medi-Cal managed care plans, not Medicare, not VA. There's 139 programs, plans right now, and 30 million Californians. And DMHC is your friend. We're going to look at that website later. Specific examples from their website about what you are entitled to includes extended release pills. Now, some of us, even if we have to take a pill one time a day, do you ever forget? A lot of medicines have to supposedly be taken 2 or 3 times a day. Hard to remember ourselves, but if you're trying to chase someone who doesn't think they need medicine or doesn't want their medicine, it's a lot harder to chase them down 2 or 3 times a day. The once a day medications are often coded, so there's a delayed absorption. So they often have fewer side effects and they are just as effective. So those are medically necessary. Also injections. It's been shown that if someone gets an injection of a medicine every 1 to 3 months, there's less relapse than if someone takes pills. Okay, that's been proven. More recently, ketamine. A couple of years ago, ketamine was hardly ever used. You probably hear a lot more about it. Not as a first or second line treatment therapy, but it's really, really helpful for depression. Most people, psychiatrists would rather use a nasal spray or the lozenge because it's easier to administer. With rare exception, there are some places that give IV infusions of ketamine. That's not FDA approved. The FDA has only approved IV ketamine to be used by anesthesiologists. But that's not to say that some people out there do use IV infusions of ketamine. How about TMS? Anyone here know about TMS or has heard about TMS? Yeah, transcranial magnetic stimulation. It's a softer treatment. In the olden days, they used shock therapy. TMS has been around now a number of years. It was originally just used for depression, unipolar depression. Now it's evidence-based for unipolar, bipolar, and even OCD. And TMS can be dramatically helpful, and it is covered. You are entitled to that if a medicine or two are not effective. How about EMDR for PTSD and trauma, and DBT for borderline personality disorders? Those are treatment modalities that are often necessary, and they are covered by insurance if you meet those criteria. And then what about frequency of therapy? Ever been told, oh, your loved one has severe depression, has been suicidal, and they can only see a therapist once a month? Anyone ever gone through that experience where you're told, oh, once a month? If you have a significant mental illness, you are entitled to weekly therapy, and DMHC will back you up on that. How about one-on-one therapy versus group? Has anyone been told, you can't get one-on-one, but you can be in this group with 20 people who don't have your diagnosis? Anyone? Yeah, okay. For a significant medical illness, a group does not replace one-on-one. Groups can supplement it, can be optional, but if you have a significant mental illness, they have to provide you with one-on-one therapy. And therapists that have openings on their panel, which I know is hard because right now we don't have enough therapists in the country. Next, there's acuity of care, acuity of level of care. In other words, there's a therapy session in the office once a week, and then there's inpatient hospitalization, and then there's several things in between. What are you entitled to? It really depends. If one can do fine and thrive with episodic office therapy, that's fine. Levels of care that are higher are IOP and PHP, intensive outpatient programs, and partial hospitalization programs. Those meet for several hours a day, 1 to several days a week, and many individuals need the IOP and PHP. The next step up would be a residential treatment center, RTC. Those are live-in. If someone needs more supervision and structure than you get from outpatient treatment, the next step would be RTC, Residential Treatment Center. An excellent example of that is the John Henry Foundation in Santa Ana. This provides long-term residential care to adults living with schizophrenia, and they support their families. The residents here live in bungalows. They have nutritious meals, daily activities and outings, transportation to doctor visits, on-site psychiatrists and therapists, and the most loving and caring staff you can imagine. Okay, I probably sound a little biased. My son has been there for 10 years, and for several years, his insurance company had to cover it. Okay, but I had to do what I want to teach you how to do. There are many examples on the DMHC website of people getting RTC, residential treatment centers, for their loved ones. In fact, most families who apply for an RTC get it, vast majority. Now, the fact that most RTCs, or there aren't enough RTCs and they're often inadequate quality, is a topic we should discuss next year. Now, if someone has higher needs, then the next level up is inpatient hospitalization. And if they need to be hospitalized, you have to get that. They can't say no if it's medically necessary. Who decides that? Generally a psychiatrist, a 5150. Who decides how long someone stays in the hospital? The insurance company cannot say, oh, we'll only cover 4 days. Anyone heard of that? Insurance company cannot discharge you prematurely. Now, the only one that discharges you is a psychiatrist. Now, why do psychiatrists discharge people prematurely when they have no chance of recovery, no chance of rehab? They haven't even been stabilized. I get a little emotional on this. That's a topic we can't get into today, but it's the psychiatrist who writes the discharge order. The insurance company, though, cannot say, oh, we won't cover this if the psychiatrist wants the person to stay in the hospital. You have a question, a comment?
And there was always pressure from the insurance company on the doctors to discharge. They say, we're not covering any more days. Now, they can't
Okay.
legally do that now. Maybe they could do that in the past. But when they got the word from the insurance, the doctor said, well, your insurance wants to discharge you.
Yeah, there's insurance companies cannot discharge you, and the DMHC will stand by you, but it's up to the psychiatrist in the hospital. I've helped families where the outpatient psychiatrist wanted someone to stay in the hospital and get conserved, and the inpatient psychiatrist refused. This is a topic for another day. The insurance company cannot force discharge or cut off coverage if the psychiatrist wants them to stay in the hospital. That's
Undue influence on some of the psychiatrists who are hospitals.
That's a whole nother topic, and I don't disagree with you. I don't know what to say about that, but I agree. One last category of what you are entitled to are some experimental investigational treatments. Whoa, that was news to me last year. And an example I gave last year was the wilderness therapy programs. Whoa, in the past, these were programs that I heard kidnap people. There was a lot of abuse, some deaths. They are now evidence-based for certain indications. These wilderness programs can really help turn around lives, especially some adolescents. And it's evidence-based, and there's example on the website of these being covered. So what is not covered? What are you not entitled to? You're not entitled to the most newly released drug. I call them the Me Too. It's much more expensive than what's already there and not any better. No, you're not going to get that. How about brand name? Who thinks that brand name are better than generic? Anyone think brand name drugs are better? They're not. There's no evidence, because for a generic to come out, it has to show bioavailability. It has to show that enough is absorbed into the body to be equivalent to a brand name drug. So if you try to get your pet brand name, you're not going to get it. How about genetic testing? A new thing, or I hear more and more cases where a psychiatrist will recommend this genetic testing test to see what drugs, how they're metabolized in a favorable way for the patient. This is not yet evidence-based, and it does not show that it helps with improved treatment. So even though in my support group, I've heard cases where someone got it, it's, again, not evidence-based. And acupuncture. I love acupuncture, but it's not evidence-based for significant mental illness, although very little calms me down as much as an acupuncture treatment. So how do you get it? Okay. How do you get what you need? You have to ask. You have to ask and appeal. Okay. You have to ask and appeal. If you don't ask, if you don't appeal, you're not going to get it. You're guaranteed to get nothing, and they win. So be a squeaky wheel. I used to have a lot of trouble advocating for myself. But when it came to my kids, I was a ferocious mama bear. Okay. Start a paper trial now. I guess that's called an email trial, a computer trial. Keep all the documents, keep all the reports, write the notes every time you talk to someone, write the name of the person you talk to, and get everything in writing. And if they say no, get the denials in writing, and then ask, how do you appeal? Okay, there's 2 levels of appeal, internal and external. The internal appeal is through the insurance company. They're in charge. Okay, you go through a process. They will tell you, the membership service, the ombudsman, someone will tell you, how do I make an appeal? And you write the appeal and you ask who's deciding. Is it, is a dermatologist deciding if someone needs TMS? It has to be someone that's qualified, but you can find out, is it a committee? I used to actually be on a committee that did this. Is it a committee or is it an individual? And then their decision has to be timely if it's not an expedited case, usually 30 days. They give you an answer, and if they deny, they have to write, why did they deny? Did they misinterpret your request? Did they say it's not a benefit? Are their facts wrong, or did they say it's not medically necessary? That is, again, a gray area. If they deny your appeal, they have to inform you in writing about the denial and where you go next. Usually in California, that's the Department of Managed Healthcare. We're going to go to that website shortly. If you go to the DMHC, you put your case in writing, you give them all the information you can, and the insurance company is required to provide all of their documentation and their reason for denial. And then it's sent to an independent body. It's called IMR, Independent Medical Review, which is 1 to 3 physicians with a relative specialty and scope of practice, and they review your case and they have the final say. Okay, your insurance company is required to follow what they say. The decision will usually take weeks unless it's an expedited case where it comes back in days, and you're going to see how fast some of these decisions come back. And you're probably wondering, okay, is it worthwhile going through this process? Am I likely to get what I need? So we can look at the numbers, and in 2023, 72% of your appeals to the Department of Managed Healthcare, you got what you needed, what you wanted. 72%. Now, this doesn't differentiate mental illness related requests from non-mental health, but the numbers kind of are comparable. 72% of the case, you get what you ask for. So yes, it is worthwhile. Now, there's a difference by insurance companies. Just to give you Blue Cross, Anthem, 75% of the appeals were overturned. 83% of Health Net, they had like the worst record, and Kaiser actually has 50% of their cases overturned. Not something to brag about. I don't think 50% is anything to brag about, but there is a difference between the insurance companies, and you can see on the website how each insurance company pans out. So let's look at now I'm going to need Chris's help to get to the website. I'm not really good at the computer. Thank you. Thank you, Chris. So this is what you can do at home. It's very similar if you have an Apple product. So you type in California Department of Managed Healthcare, and look what you get. Voila. This is what you start to see. And I want to look at something, healthcare in California. And look at this. You can't see this. I'm insured now what? Can't quite. This is a section. Okay. So I just discovered that when preparing for this talk. It says, congratulations, you have healthcare coverage. What? Now what? Oh, what is covered? Let's see. Okay, so let's look at basic healthcare services. Whoa, and then there's behavioral healthcare. Now, behavioral healthcare is a term that includes substance use disorder and mental illness. It's under the title of behavioral healthcare. How much time do we have? Am I running behind? How much time? Okay. So I sometimes start talking too fast when I feel rushed. So here's behavior healthcare, and there's information here, mental health use and disorder, and it gives you a whole lot of information on just what you want to know about and stuff that I've said. So this is an amazing resource to look on here. So if we go back to the DMH, their page here, I'm going to show you how to look at actual cases where you brought an appeal. Now, my case is somewhere there because I went through this process for my son, and I got him covered at a residential treatment center for a couple of years. So I went through this process, and I can tell you it works. Okay, so we're going to go to data, or is that data and research, and then search independent here, medical review. And then we go here to search IMR decisions. Can you all see that from where you're sitting, or is it, you can see it okay? Okay. So then this is what it looks like where you want to look at different different kind of cases here. So is there a particular topic that we want to look at? Well, I'm going to start with looking at medical necessity, because that's generally most cases. I mean, there's experimental and there's urgent care, but most cases that we're appealing are dealing with the issue of medical necessity. And then we can look at the determination, is it overturned or upheld? We'll look at any determination, and let's look here. I'm going to put for search, keyword search, I'm going to put mental illness. Okay. And search. And look what we come up with. Here's this page. So look at that heading. It shows you an ID number. No cases are identified with the person. So my case is somewhere there, but my name is, and my son's name is never there. The type, that's medical necessity. It could be experimental or the urgent care, and then determination, is it upheld or overturned? Overturned means the insurance company's denial was overturned. You got what you needed or wanted. Upheld means that they agreed with the insurance company. And then this column is the year. Severity, expedited cases. Look at how fast the response came back. The first case here, 4 days for it to be reviewed, 11 days for a response. So I think that's pretty decent. Some can be faster. The age range, look, the age range, it tells you some are minors and some are not. And then the category of, what's the category here? And what are they asking for? And this is, I'm missing the far right column, Chris. I had the same problem last year. Sorry, folks. How do I get there? Change the font. Okay, thank you. I just turned that. Okay. So on the far right, you see what is it like? There's a couple here that are RTC, residential treatment center. Then there's pharmacy and hormones. So, now going back. See, now, how do I go back? Two fingers? I don't have the magic touch, but. Okay, I don't feel so bad. He's having trouble. Okay, thank you. So to look at a particular case, you just click on this plus number. Now let's find a particular case. Let's go to this one down here. I'm clicking on the plus. Okay, and then what you get to see is an explanation of, now this case, it was overturned. You got what you needed. And there's a lot of words here. They used to just be a paragraph, and the team would just give a brief summary of why they decided. And then a couple of years ago, they decided they wanted to have a more objective measure. So now they have some tools where there's like 6 categories, and they judge each of those categories and determine a numerical value that determines the severity. So, but if you go through this, you'll read about the case. This case, an adult had severe alcohol addiction, was pregnant, intoxicated, high risk of withdrawal, severe mental illness, suicidal attempt, severe childhood and adult trauma, is on psych meds, but has persistent hallucinations. Sounds pretty sick to me for both the patient and the fetus inside, and had history of multiple drug overdoses. Well, the insurance company refused to authorize a residential treatment center, but the family, they were overturned.
Can I say something
Go
really
ahead,
quickly?
please do.
Can you go back to that text for a second?
Let me go back here.
So I think you may remember me saying this about Senate Bill 855. One of the other important parts of this that I mentioned, you can see in the findings here, where the criteria that were used to determine medical necessity and the right level of care it's at the top. There you go. Is in this case ASAM criteria. The other one you'll see is locus, and then Cal locus. And what those are they're from nonprofit organizations. In this case, ASAM is from the American Society of Addiction Medicine, and they are standard criteria that everybody has to use. So facilities, insurance companies especially, because before we had that law, at least, and this is just California, so that's important to know. Before we had that law, it was whatever criteria were in my judgment, in my clinical judgment, or my medical director's clinical judgment, et cetera. So this is really important to look out for, not only here, but when you see those acronyms, that's what those mean.
Thank you. Good, very good points. So here's another case here. Expedited, that means, look, 5 days, 9 days. I think that's pretty quick to get an answer on something very complicated. This happens to also be an addict. There are a lot of cases that are dual diagnosis. This is someone who has type 1 diabetes, hypertension, hepatitis C, probably from shooting up, fast heart rate, low blood pressure. Sounds pretty sick. Severe mental illness. Is continually craving fentanyl and multiple overdoses. So pretty sick person. They decided this patient did not need to be in the hospital, but needed more than an outpatient program. And so they were, the insurance company's denial was overturned. Any questions on this kind of thing? I'm going to go through a few more cases and feel free to ask questions. So, let's see, 411. Question? Sure.
It's important, not just for you and your loved one, but you can change what the situation is for other people in a similar situation going forward. When we try to get TMS for my wife, it was an automatic denial as experimental. And there was a website that the manufacturer had that gave you resources for appealing, and we appealed. And it took about 3 months, but we never got the denial reversed. What is, they changed the category from experimental to evidence-based. And everybody in California can now get TMS after that. Now, was it just us? I don't think so. Probably other people were appealing at the same time, but we were part of that.
And this really makes a difference to appeal. I mean, TMS is a great example where it's new. It comes out. It's a new kid on the block, and actually recently there's a new drug, Cobenfy, Cobenfy. Did anyone read about that? It's the newest psychiatric drug that's been released. It's totally different from any other antipsychotic. It uses a different mechanism and has much fewer side effects. It has but much less than others. Doesn't cause weight gain, etc. Cobenfy, Cobenfy, it's just been FDA approved. And so, is that going to be available for our loved ones? Well, not too quickly. It was released a couple of weeks ago.
They had a video conferencing thing going on today. So I couldn't go to that, but I'm sure there's stuff on the website. It's Bristol Myers Squibb. It's the pharmacy.
I'm interested. Many years ago, I read in the British Journal about a medicine called Vraylar, which you've probably all seen advertised on TV. Vraylar, Vrylar, and I read this article, and it said it's really effective for negative symptoms of schizophrenia, which are when someone is catatonic, mute, doesn't move very well. My son has very heavy negative symptoms, and his other antipsychotics were not helping a lot. My son then became the first person with his insurance in Southern California to use it. He's a poster child. It turned on the faucet. It was dramatic. I told everyone in my support group about it. They all went and asked their doctors, and no one else had as good a response as my son did. But, if you ask for it, now they kind of know that I'm a squeaky wheel, and I, it was a reasonable request. And, so new drugs come out. You can't expect that, you're going to get it the first week it comes out. If your loved one is stable, they're not going to want to change their medicines. People like to see a track record. Insurance companies need to get it on their formulary. But for someone who's not doing well, who has failed most of the other antipsychotics or has not done very well, it's worthwhile to ask for the new kid on the block, because this is not a Me Too drug. This is a new, it looks like it could be dramatically helpful. So don't be afraid to speak to the treating psychiatrist. And if they say, well, I'm not familiar with it, then you can get them information. That's not an acceptable answer. What kind of pushback do you guys get when you ask for something? Anyone? Do they say it's not in the formulary? I already said we can't, that's not accepted. Anyone get pushback when they ask for something? What's the most common pushback you get?
And the case manager at Blue Shield was very willing to speak with the out-of-network residential treatment facility, and the director of the facility said, oh, no problem, have her call me. And it went nowhere. He didn't even engage. It was the weirdest thing. And because they do pay, it's quite expensive, but Blue Shield does cover out-of-network $500 a day. But we were trying to get more. But I think that what the facility charges versus what Blue Shield would be willing to pay in a single case agreement, they wouldn't even discuss it. So I'm still pursuing it, but so far not successful, even though she's met all her, out of pocket, all the deductibles, heading toward meeting the out of network deductible for this year. It's been a rough year.
Go ahead.
That's coming up a lot, that single case agreement issue, where what in this case Blue Shield is offering or what we're offering, and willing to say, there's a whole nother conversation about fee schedules and things like that. And for companies, I'll just say for Blue Shield, our fee schedule is horrible, which we're trying to lift up as a parity issue, because it's it's embarrassing to say it's not even at market standard. So I can have residential treatment, let me finish really quick, residential or facilities, providers, the outpatient network, whatever, and it shows it's in network, and they won't take our members because they know we don't pay as well. And it's become it's a business issue, but it's also obviously a care quality issue. Sorry, go ahead.
Yeah, issue of a longtime family psychiatrist who sees virtually 3 out of 4 family members, and they are out of network, and they could not reach a out of network agreement. So now we have to get them to bill us individually. And then someone's spouse died in their office and we can't get the bills. But how do we get, and whatever they offered on the out of network thing was unacceptable. They couldn't meet their nut for the day on that, let alone make any money. So what can you do about that when they're not giving reasonable pay? And with psychiatrists, it's very common. There's many psychiatrists out there that will not take any insurance program.
And you're kind of stuck with, generally if you have insurance that, you do need to go with someone on their panel, that's, kind of if you go to, but.
Right.
And if we can get the paperwork, which, because they're now independent, they're a small office and somebody has this problem and they're backlogged, we can't even get the paperwork. But then I've got to sit there and file paperwork because they would not, agree to a customary and usual fee, which is not, I don't think is outrageous.
That's a problem, with the bureaucracy. I know at John Henry, where my son got, as I said, a couple of years coverage, the amount of paperwork that John Henry had to fill out was so onerous. And I think that it was purposeful. I think it was very purposeful. They had to keep going over and sending. And, the amount of paperwork was so onerous. And I was talking to someone out here who runs inpatient programs. The amount of paperwork is onerous. And, John Henry doesn't have the staffing. It's a lean staffing to do that much paperwork, which isn't, so that they're not excited about having any more patients. Let's hold up a few questions till we get to the end. So I can say that John Henry is not really, after my experience, and I got another family to get the insurance company to cover. The paperwork was so onerous that they really don't want to deal with it. And how can you blame them? Because it takes a huge amount. This company I was talking to outside, they used to have 2 staff people to handle paperwork. Now they're up to 7 for, I forgot what the number is, but yeah, the paperwork and the bureaucracy. Let me just do a few more cases and then we'll open up to more questions here. 2061. Okay. This is someone that has bipolar disorder. And this patient has suicidal ideations, feelings of worthlessness, poor self-care, unable to work, had to drop out of law school. Well, this person was obviously very functional to be able to get into law school, but then dropped out due to symptoms, migraines, a lot of conflicts. She had been in the outpatient treatment and IOP and inpatient and was unable to have adequate improvement. And let me get back. Oh, Chris, I'm having trouble here. How do I go back? Sorry, folks. Here, 2061. How can I see the far right column here?
Yeah, I'm fine with that case you want.
Okay, yeah, just so I can see.
Yeah.
Okay, thank you. So this individual who it was a law school student wanted a partial hospitalization program, had failed an IOP, had failed other kind of programs, and this person got it. Okay, got a partial hospitalization program is a step up from intensive outpatient programs. So again, different levels of care. Each case is different. I have a couple cases that I have, but I won't show you. So about getting DBT, we had a really great talk on about DBT treatment for for borderline personality, etc. There's a couple cases. Actually, every case I saw of someone asking for DBT got it. This was an individual that wanted one-on-one DBT treatment while in an IOP. Was a typical bipolar patient who had trouble engaging with clinician, poor family support, and trouble engaging with a clinician. You know, they got DBT, and the issue is how do you find someone that's as highly skilled as the person that gave our presentation? That's a whole nother issue. But there are cases also of people wanting EMDR for trauma and PTSD. If you have the medical indications, you have trauma and severe PTSD, you can get someone who is trained and expert in that area. Now, how do you know? It's like everyone says they do CBT these days, right? Everyone does CBT. Well, what about CBT for someone with schizophrenia? It's different. Everyone can do CBT maybe for insomnia and anxiety, but to be able to do CBT, which has been proven to be helpful for our loved ones with schizophrenia, that's a small population. And so again, you want to get someone that's highly trained and has the skills to help you in that, that niche. And that's a whole nother question. I have other examples I'm not going to get into because I want to have some more discussion and questions. Do you have any, Nicole? Do you want to add anything? No. Did you have any other? Go ahead. Go. Oh.
Me? Oh,
Yes.
okay. If we could go back to SB 855, as I understand it, you said a health plan has to cover out-of-network provider if there's no available provider within the network. Can you elaborate on availability? Does that mean, yes, they have a list of providers, but you have, to wait for 4 months to see a psychiatrist? Or what does availability come down to?
Yeah, that's a good question. Thank you for giving me a chance to clarify. You have to be able to see somebody within 10 business days if it's not urgent. If it's urgent, that's 48 hours. If it's psychiatry, so about anything medication related, that's 15 business days. If your insurance company cannot meet that, like you've called around, nobody can see you like you described for another month, call the insurance company back under 855. They need to find you somebody to see within those within those guardrails. That is then compliant or not compliant.
What department,
language.
what department within Blue Shield would they call, or insurance company? Like, how do you find a person to talk to?
There shouldn't be a specific person that should, at least at Blue Shield, that's our customer care.
Customer care.
Yeah. If it's a really complicated, either diagnostic scenario or perhaps there are other medical issues or chronic, something that makes it a little bit more complex. Generally, those customer care pull in care management to help with that.
So for example, an initial appointment with a psychiatrist to get a diagnosis and
That's
possible
the-
medication, would that be a 15-day?
That's 15, yes.
Okay.
15 calendar days or 10, yeah, if it's a therapist. But that's only if it's routine. If it's urgent, so there's suicidal ideation, homicidal ideation, not imminent. If it's imminent, that's an ER visit, right? Unfortunately. But just short of that, make something urgent. And if you're not sure, but it feels urgent, that's also urgent. So there's no criteria in a way that there is with some of the other decisions. And that unfortunately really relies on the health plan to interpret. Our standard for urgency is pretty low. If you're urgent, then it's urgent. Did that answer your question?
And
Yeah,
that's,
I'll talk to you maybe afterwards.
Okay, yeah.
I mean, that's
I'm
a
glad
good
to.
question, because I know there are not enough psychiatrists and therapists and social workers in California to fill the openings. I mean, the
Yeah.
Department of Health, I think every insurance company is just on their knees
We
trying
also-
to get more therapists. So access is an issue.
Yeah, very.
Department of Healthcare fines just about everyone because they're out of access. And this is a complaint we hear everywhere.
Yeah, everyone who I have called says, we're out of network, but we'll generate for you a super bill so you can apply for reimbursement. Could you talk about that for a moment, how that fits into the process?
Sure. So that really works off of your benefit plan. Thank you. If there are outer network benefits, that's kind of the smoothest route. I think we haven't had, this just went in force in July 1st. What we haven't had yet is the super bill that comes through with a benefit plan that doesn't have out of network benefits, but you send us a super bill because I couldn't find anybody else. So that this law says you need to pay for that. That, to my knowledge, hasn't come up yet. I'm excited for when it does, because I think that forces some issues. But usually I see that if it's out of network. It's a good question. I don't know that someone. No, the preferred piece is where, yeah, that's the part that I hate is it's not, because oftentimes it's not, I don't prefer seeing somebody because I just like them better. It's that I've been seeing them for a long time, or my family sees them and they know my family. And so it's preferred in a way that's clinically appropriate or therapeutically appropriate. But that preferred word, I know in the past, it's certainly gotten me in trouble as a consumer. Yeah.
This will
I'll
have,
talk more about it too.
forgive me, this will have to be our last question.
Oh, how about two questions? One more question after that. A quick one, quick.
All right. So I just wanted to follow up on the answer you were giving. So what is the criteria for available care? So I'll give you my example. I use an out-of-network psychiatrist for family member who's highly specialized and very much aligned with the needs of my son. And I really am not confident that I could find a psychiatrist in network that could provide a similar level of care that was very specific to his diagnoses. So is that something you could appeal with your insurance company to get coverage and even reimbursement for prior bills? Or is that, are they just going to say, we've got 50 psychiatrists who could see him anyway,
So the previous bills, I don't think so. I think it depends on the plan. And to be honest, I'm not exactly sure how we would do that. I don't think so. But that said, the criteria is still the same. It's the appropriate specialty for what you need, and then the urgent and non-urgent timelines. if those three criteria, or those two, in that case, the timeline and the specialty aren't, if those needs aren't met, this is also true for facilities and applies to residential treatment and all of that. We have to help you find somebody who does meet those criteria in network. And if we can't, then the one that you have is the one we work with and cover. Which, I'm sorry, I don't
How do you
understand
establish the criteria?
Well, it's your special, I meant more or less what you're describing as the very specific specialty or technique or medication, however it's coming up as the very specific treatment consideration. Sometimes it's diagnostic, sometimes it's somebody, it could be gender, it's any of those things that make this psychiatrist the one your son needs to continue to see. That's the criteria.
Quick
Sorry, I
question
wasn't
from Lynn. Can you make a quick question? Talk fast.
So I'm on both sides of this. So I'm a consumer and I am a mental health provider and specialist in EMDR therapy. And in my state, I'm not in California, so I will say that my state is, well, different. But the super bill process, for those who are asking about the super bill, I have found to be really disappointing. My clients do not get the money because a lot of times they have out-of-network deductibles that are so extraordinarily high with their plan that it just doesn't matter. And that's my case too. So my loved one, our out-of-network deductible here is we have Blue Cross Blue Shield, but out of a different state. But again, I get the super bill and it just doesn't matter. So we just pay because we cannot find a provider in this state that takes Blue Cross Blue Shield that has openings. So the other issue with the single case agreement as well, I have never had a client been approved for a single case agreement to see me because they say, well, there are other EMDR providers in your city, but they may not have the level of expertise that I do. So again, this is a little challenging. I don't have the answer for that, but I did want to just bring that up from the provider side of things as well.
Sure.
It's been a very difficult process working with the insurance companies.
Understood.